We're delighted to have a program called Technology, Health, and Equality. It's a bit different from our normal theme, but it's actually very consistent with what the museum is about. As you all know, we are in the middle of the greatest revolution in the history of mankind. It's called the information age. We at CHM see ourselves as the most important institution helping the world understand the relationship between computing and culture. I love the quote that Nicholas Negroponte of MIT put out. Computing is not computing anymore. It is living. How true is that? We look at the history and the unprecedented impact of computing, and we also look at the future possibilities that are coming our way. Tonight's program is another exploration of that phenomenon. I'd also like to point out that every one of our live events is much more than just an evening of education and entertainment. This conversation will add to our collection of digital records from this information revolution. Tonight's program, of which you are all a part, will be available for viewing not only tomorrow, 5, 50, and maybe 500 years from now. You are part of the history of this unprecedented revolution. Both KQED and C-SPAN are recording tonight's program for viewing at a later date. October 11th will be the airing date on KQED radio for tonight's program. We're also streaming live on Facebook. So welcome to those of you around the world who may be watching on your Facebook live stream. You too can ask questions. Use the comments section under your Facebook live feed, and we'll try to get those questions in front of the moderator tonight. If you're tweeting or posting to Instagram, we encourage you to use the hashtag CHMLive, and you'll appear on our live board. That's kind of fun. Enough about all that. Let's get to the stars of the program. I'd like to introduce Dr. Anthony Iton. Dr. Iton, or Tony as he prefers to be called, is the Senior Vice President for Healthy Communities at the California Endowment. He's been there since October of 2009. The Endowment's Building Healthy Communities initiative is a billion-dollar program designed to change policy and encourage civic engagement in 14 California communities that are affected by healthcare inequality. Prior to that, he served as director and county health officer for Alameda County's public health department. And if you look up his resume, you'll see a string of academic degrees that's very impressive, to say the least. He's going to be interviewed tonight by Vanessa Mason. Vanessa is the co-founder of P2 Health Ventures, a public health tech venture fund. She's also CEO and founder of Riveted Partners, a digital health consultancy. She knows what she's talking about. This should be fascinating. Please join me in welcoming both Tony and Vanessa to the stage.
All right. Well, this promises to be a lovely evening. Just before we get started with interviewing Dr. Iton, he has a wonderful video to show just why Building Healthy Communities initiatives got started and really the impact that they've had already. So we're going to watch that first. Play, please.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs. They're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in B-Ville, less than 1 mile away. They're similar in so many ways. But here's the thing. On average, residents of Bville will die more than 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher, and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventive health care. On the other hand, Bville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhausts from the nearby highway. And for food options, Maria's only choices are Bville's many liquor stores, fast food places, or convenience stores. The schools in Bville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, having to juggle so much to find healthy options can be an overwhelming source of chronic stress, which is a serious health risk factor. In fact, for all the residents of Bville, chronic stress drives health problems like obesity, diabetes, asthma, and heart disease. How did A-Town and Bville get so different? Well, in many cases in cities and towns across California, the root cause was racial and economic discrimination. Over the generations, poor white people and people of color were pushed to less desirable parts of town, where banks refused to lend money, businesses left, jobs too, schools declined, and the neighborhood crumbled. Everyone who could move away did. And what's more, when communities like A-Town and Bville are so unequal, Bville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you'll live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, and upper income, die younger than their peers in other countries. In fact, our life expectancy is 43rd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality, and extreme inequality hurts us all. So what do we do? Well, if we're all going to be healthier, we don't just need to help the folks in Bville beat the odds. We need to change the odds for everyone. And that's what we're doing. There's a movement happening. We're Californians. We don't follow. We lead. We are building the power to make health happen in communities across the state. We are coming together to build one California, a smarter, more inclusive and equitable state that creates health and opportunity for all of us. Join us. To learn more, visit buildinghealthycommunities.org.
So thank you so much for bringing this video to us. Sure. It's a really wonderful way of illustrating what is a very foundational public health concept that I think for people outside of this space have a hard time understanding. And I know that we're both in this space of public health innovation. You're pursuing it through policy, myself through more on the technology and financing, but I really want to hear more from you. How did you get started with this research and kind of start telling the story? Because I think as we move along this evening, you guys will be able to see how technology is playing a role both in the discovery and sort of moving this forward as well.
Yeah, so it's actually interesting because it's kind of a technological story.
Yes.
I'm going to tell a sort of a quick version of it, but I went to medical school at Johns Hopkins, and for those of you who may not know, Johns Hopkins Medical School is located in East Baltimore, which is one of probably the worst slums in America, if not North America. And it was a real shock to me because I had grown up in Canada, and Canada has sort of a deep level of investment and its people: universal health care, universal child care, paid sick leave, vacations, heavy investments in public art and infrastructure. So when I grew up in Montreal, and when I got to East Baltimore and I saw that the conditions there, I was really quite shocked. And it sort of triggered this sort of thinking in my head that in the US, does where you live ultimately shape your health more than any of your genetic factors? And so I kind of got interested in, when I graduated medical school, and then I went through a whole bunch of studies in policy, I got interested in how do you illustrate these differences between neighborhoods and the impacts, the ultimate cumulative impacts on people's health using technology. And at the time, this was in the early 1990s, geographic information systems were just sort of coming online. And I kind of got hooked on GIS. And so if we can bring up the slides, I just want to show just a couple of slides of sort of how we approach this work. Do I do that? Okay, there we go. So most of you probably don't recognize this, but you will all have one of these at some point in your life. This is a death certificate. And when you're the county health officer, you're the registrar of all births and deaths. And in Alameda County, there are about 10,000 deaths a year. And so I got really excited with the technological possibilities of using these death certificates to start painting a picture of the distribution of death across Alameda County. And so each death certificate needs my signature on it before the body can be buried or cremated or whatever is going to happen to it. So it's a real opportunity to get very good data, because you can refuse to sign a death certificate until the certificate is completely filled out and you have all the data that you need. And on the death certificate, the data that's most critical for doing this is the age at which somebody died, their race, ethnicity, what they died of, and where they lived. All of that information is on the death certificate. So you can take a death certificate and you can plot a map. This is Alameda County, which is shaped like a boot, and each of those boundaries there are census tracts in Alameda County. There are about 150 of them. And you can calculate in any given census tract the average age to which somebody can expect to live. And when you do that, the green areas are neighborhoods in Alameda County where people can expect to live greater than 80 years. The red areas are areas where people can only expect to live about 74 years. And then the yellow is in between 74 and 80 years. And you notice very quickly that there are clusters of red areas. There are neighborhoods in Alameda County where people die earlier than others. And this is a phenomenon that is, you can track this over decades. This is not a fluctuating phenomenon. These neighborhoods have been essentially concentrated neighborhoods of premature death for decades. And so this was very interesting. This ultimately ended up on the front page of the San Francisco Chronicle. And people would say to me after this happened, it caused a bit of a stir. They'd say, "What's the story with Alameda County? Why is it so inequitable in Alameda County?" And my answer was, it's not just Alameda County. So we had to start looking around the country for other places where we could replicate this GIS analysis. And it was something that wasn't really done at the time, to look at relatively small geographic areas and calculating life expectancy for a neighborhood, and then comparing those neighborhoods to other neighborhoods in the same city or the same county. So we took our map of Alameda County, and I had to go back to Baltimore because that's where I had gone to medical school, and I was, this had triggered my whole interest in this issue. And in Baltimore, there are neighborhoods where people on average live into the late 50s. And so there were dramatic disparities across the city of Baltimore. We went to Cuyahoga County, Cleveland, which showed neighborhoods with 25 years of life expectancy difference between, neighborhoods that were within a mile and a half of each other. New York City, dramatic disparities there. Seattle, Los Angeles, Minneapolis, Boston, Philadelphia, San Antonio, everywhere we looked. We haven't found a city in the United States yet that doesn't have a significant life expectancy difference from neighborhood to neighborhood. This is the American pattern. And before you really had the technological ability to sort of bore down into neighborhoods and use large data sets to sort of discern these patterns, we didn't really understand this. We now understand this, that you can have two contiguous neighborhoods with a life expectancy difference of 15 years. That's, and that's a fixed difference. It's not something that fluctuates from year to year. And trying to understand that is what I've spent my career basically doing. So that's how I got into this.
Yes, and that's certainly the problem at hand, and I see this in my work as well. Like we are a fund that is focused on investing in prevention and in healthcare disparities and trying to fund technology that addresses those. So the question of disparities is one that is unfortunately universal and persistent, and we're going to get into maybe how we can address that today. So moving more into the policy perspective, like we know that the zip codes and health relationship is here. The ACA is on everyone's minds. Is it or isn't it going to be gone at any point in time soon? So from your perspective, like how has the ACA actually helped to decouple the relationship between zip codes and health, and how could repeal actually affect that relationship?
Yeah, so this is a little complex. Actually, it's not really that complex, but you might think it's complex the way I explain it. Healthcare is important for you because obviously when you get sick, you need access to healthcare. Healthcare helps you avoid, adverse consequences from being sick. But that's not the most important reason that the ACA improves health. One of the things that we try to explore in these neighborhoods where you have chronically low life expectancy is trying to understand what are the drivers of that, what's happening to people in these communities. And the thing that you come away with most obviously is that people in those communities, mostly their low-income communities, are facing inexorable stress. Basically, every system that they're trying to engage is failing them. Transportation, housing, employment, criminal justice, even water in some instances. So people are navigating an environment where they're constantly facing stress. And stress is basically a balance between resources and risk. And in those communities, they're facing enormous risks and they have limited resources. So they're constantly out of balance. And what that does is it creates, the fancy word, a way of explaining it is called allostatic load, but it's really chronic stress. And that changes your physiology and that changes your genetic expression. And over time, it mimics premature aging in these populations. So the issue of the ACA is that the reason the ACA is particularly beneficial for your health, and all of the Western democracies around the world that have universal healthcare systems sort of recognize this, is that it reduces stress. It allows you not to have to worry about what will happen if you get sick or your children get sick or you get hit by a bus or what have you. So that aspect of it, by reducing the allostatic load, actually has profound beneficial health impacts. And that's the fundamental approach that we've taken in our work.
Okay, wonderful. And it's something that we've been keeping close track of too. I know that Tom Price just announced that they're starting to scale back bundled payments. This idea of value-based care that got brought in a lot more with the ACA and actually paying for outcomes, is starting to introduce questions about whether or not whether that's still going to be around. So getting more into the work, so how are your local partners really using technology to improve the health of the communities that you work with?
Yeah, so I love technology. I mean, it's just fun to work with in health. It's great. We have data sets now that we never had before. We have the ability to manipulate this massive tomes of information and get at relatively small questions. But the thing that we've recognized, I think, that has been most important about technology, where the real potential lies, because of this recognition that health, and we're not just talking about low-income people, we're not just talking about people of color, we're talking about all Americans. All of us in this room are experiencing allostatic load. It varies in terms of its manifestations. Again, this risk versus resources balance. But a lot of the risks are societally created risks. They're unnecessary risks. They're man-made. And the way that other societies attend to them is really through policy. Universal health care is one obvious example of that, but also subsidized education and housing policies that reduces the risk that people have to face. So this notion that people are experiencing this heavy risk, this burden of risk in their lives, is the fundamental issue that we're trying to address in tackling these problems. And how does technology work for that? Well, we recognize that when people can participate civically in their environments, because fundamentally we're talking about people who feel they lack control over what's happening to them, and that lack of control is very bad for your health. And I can go into the physiology of that, but bottom line is feeling that you lack control or agency is bad for your health. And so if you want to help people develop agency or a sense of control, one of the ways that you do that is to organize them, to bring them together with similarly situated people, to have them to start tackling things that are presenting essentially risks in their lives. Now, one of those things is government, unfortunately, or the lack of policies where people are looking for policies to benefit them or their families. So technology that allows people to participate civically, to vote, to express their opinions locally, whether it be at, city council, school board, with the services that they're getting, to rate those services, and so that there's accountability to some of the service providers, that's actually health protective. And so part of our strategy is to essentially facilitate voice in community so people have more control over the resources that are ostensibly designed to serve their needs. And they also have the ability to hold systems accountable for more equitable use of resources.
Great. And I know for a lot of you who are technologists and hearing us talk about healthcare, it's kind of a hard thing to wrap your mind around that health care is not actually the same thing as health. I think when we look at media and we read about it, that those two things often get conflated, but they are in fact two completely different things. And so a lot of what Dr. Iton's work and a lot of what my work, and even thinking about a fund and the startups that we are investing in, we are specifically interested in addressing these issues, like how can we alleviate those sources of stress, like where can technology address transportation, where can it address other sources of stress and these social determinants of health that are really driving a lot of stress and problems. So getting more, you're obviously a physician, but a researcher also at heart. So where can technology play a role in helping doctors and other researchers be able to advance this practice and really accelerate potential interventions or things that can really help to address this problem?
Well, I think one of the challenges, I'm an internist, and the paradigm of medical care is sort of like these 15-minute interventions in a cubicle, where the doctor sort of disgorges this, information, and the supplicant patient sort of, takes that in and applies it in their daily lives. That's a failed paradigm. And the notion that sort of experts hold the answers, I think, is a flawed notion. And so many of the communities in which we're working are trying to redesign their healthcare systems. They're trying to think about healthcare more from the perspective of how do we bring people together in a way where they can help each other, as opposed, and many of the challenges, the 21st century challenges are challenges of chronic disease. They're not challenges of infectious disease or acute problems as much as they were in the 19th century. Our healthcare system is still a 19th century system design, where you go into an expert and the expert gives you a drug and that drug solves your problem. The 21st century problems are heart disease, cancer, stroke, chronic lower respiratory disease, which are chronic diseases, which are more related to the environments and the lifestyles in which people are living. And those lifestyles are shaped oftentimes by policies, or in some cases it's the absence of policy in the face of abject need. And so bringing people together to essentially create the political will to solve problems is a health intervention. And the healthcare system can participate in that. And many sort of health systems that are on the vanguard are doing exactly that.
Yes, and so what are some of the successes that you've seen with calling on more political will and bringing people together?
Well, the simplest thing to think about is, we're in the Silicon Valley right now, and housing is a big issue, right? Housing is an enormous stressor. I don't know about for the people in this room, but for my kids' friends that, are either in school here or out of school and looking for places to live, they're struggling dramatically to find, those kinds of solutions. And some of them are working in healthcare institutions, some of them are working at academic centers. And those institutions have a role in helping create policy that facilitates the ability of people who want to live here and work here being able to do so in an affordable way. And what is new about them participating in sort of that policy effort is that we now know that the absence of meaningful policies in this way actually creates adverse health outcomes in the lives of people that live in these communities. So we know a lot more now, and the question is, how do we use that information to sort of apply it? So there are health institutions around the country now that are, engaged in housing policy, they're engaged in education policy, not just because they feel like they can, but because they feel that that's actually critical to the health improvement of both their workforce and their patients.
Sure, and definitely have seen a growth of this. Like, I just talked to a major health system just the other day that was just saying that, if only there was a startup that actually addressed this issue of, they know when they discharge patients and they have housing unstable patients. So these might be patients that are actually homeless, or they're just living in some sort of situation where whether because it's violent, it's dirty, it's just simply transient, they're staying with family and it's not permanent, that because their patients are housing unstable, they're not going to follow the orders necessary in terms of medication and all the practices that they need. And so for them as a health system, they wanted a startup that was going to be able to match people who had housing benefits with inventory that was on the market that took those particular benefits. But when you look at Silicon Valley and a lot of the startups that are out there, that's not really a problem that really pops up on people's radar. I think because there's a lot of entrepreneurs that haven't lived through housing instability or don't have, enough experience to be able to understand how to tackle that problem. But like you said, that there's plenty of opportunity, for lack of a better word, to really look at, how we can leverage institutions to really address some of these sources of stress. And that said, I think we're talking about the institutional level, but is there anything from a patient or consumer generated data or sort of action like that can be driven through technology to actually do the same thing, so you kind of get a bottom-up solution too?
Well, I'm not an expert in that, so I can disclose that.
Sure.
There has been an effort more recently, and let me just explain maybe for folks who don't know what the social determinants of health are, but the social determinants of health are things like housing, transportation, employment, access to healthy food that are essentially the drivers of health conditions at a population level. And those social determinants are fundamentally now being recognized as critical even down to the individual level. And so healthcare institutions now are starting to collect information about people's social conditions and the kinds of resources that they're able to access. And there's some cutting edge work happening at Johns Hopkins, at Harvard, and some other places with groups. One of them is called Health Leads, which is a technologically based organization that is focused on essentially taking that information, incorporating it into the medical record, and then matching patients with resources in the community that they need to be able to address their housing issues or their issues around access to healthy food. The next step beyond that is to sort of start to aggregate some of this data and use it in the policy space to push for policies that will essentially further the access at a community level to these kinds of resources. So there's a recognition that we've kind of exhausted the medical model in terms of trying to push essentially that model into improving health of populations. We're as healthy as we're going to get from the traditional medical technology. I mean, there are probably some breakthroughs that will come along that will help at the margins, but for the most part, if we want to improve the health of our populations, we're not going to be able to do it in the doctor's office. We're going to have to do it in the environment, in the community, changing the way that people interact with their environments and facilitating essentially stress-reducing lifestyles for people living in communities, particularly in low-income communities.
Yes, of course. And for those of you who aren't kind of familiar, there's part of the reason why we're trying to tease apart health and health care and say that the medical model is outdone is because when you look at the statistics, in terms of what actually contributes to our life expectancy, of course, is as sort of public health interventions, like what are these behavioral, social, and environmental factors, up to the point of the last 30 years in the increase of life expectancy, about 25 of those years were attributable to public health interventions, not to access to medical care. But when you look at the financing pie about like what we spend in terms of healthcare in this country, only about 3% of that goes to public health interventions, the things that Dr. Iton is studying and implementing in the Building Healthy Communities work. So it really is that we're getting what we pay for because we're not paying for things that actually work. So it's a lot of the reason, why, like, of course, like looking at policies, but like, the sort of things that lives in the shadow of the policies is really talking about financing and talking about money, which of course drives everything. So on that end, what kind of policy changes are necessary to support innovations that are going to address social inequalities?
Yeah, so I showed you the maps of places where people are living less long. We call that really a death tax. People pay a death tax for living in a neighborhood that's essentially bereft of the kinds of resources that we all know that people need in order to be able to pursue healthy lives. And there's these two researchers, one at Harvard, one at Yale, by the name of Elizabeth Bradley and Lauren Taylor, that they were looking at that traditional analysis that shows the US on a per capita basis spends more on healthcare than anybody else in the world. We spend basically twice what the OECD average is, and the OECD are other economically advanced countries. And we've been looking at this data for over a decade, saying, why are we spending so much, and other countries that are similar are spending so much less, and their health is better than ours? Not only do we spend more, we actually get worse outcomes for what we spend than other countries. And so they were looking at this data as well. And they decided to do something different. They wanted to look at per capita health spending, but then add per capita social services and social benefit spending to essentially that graph. And when they did that, typically the US is like way out at the end, the big spender, and then everybody else is sort of down the other side. When they added social benefit spending, they found that the US was now in the middle of the pack. Mm-hmm. We were no longer the big spender. When you add healthcare and social spending, we're not the big spender. So what they pointed out, and this was an op-ed in the New York Times that subsequently became a book called The American Healthcare Paradox, what they pointed out was that we have the accent on the wrong syllable. We're spending our money on healthcare and getting worse health results, and those countries that spend roughly 2 times on social services and social benefits compared to what they spend on health have better health outcomes. That's actually the right ratio. You should be spending more on social services and social benefits than you should be on healthcare if you want to improve health. So this is the American healthcare paradox. And the role of technology in this, that they could do this analysis and kind of show it so easily now, it's now relatively well known. The role of technology really is, how do you get the health benefit of that social services and social benefit spending? And that's what things like Health Leads are trying to do now, is to try to take the clinical encounter where we've invested all this money and all this effort and try to start pulling in sort of social benefits and social services to the population that's consuming a lot of healthcare services, because ultimately what's driving that consumption of healthcare services is the lack of social supports and social spending. So it's, how do we bring that into the healthcare setting to drive down the medical care costs and actually improve the health of the people that are essentially showing up in the emergency room for social services?
Yes, and it's definitely going to be a long, long effort. There was a piece written in Health Affairs, actually today, that just came out from Jeffrey Levi, who was formerly the head of the Trust for America's Health, a large public health kind of research organization, as well as Karen DeSalvo, who was formerly at the Department of Health and Human Services in the federal government and also was the former head, the national coordinator for Health IT. And so this article really talks about basically public health 3.0. How can we start investing in the infrastructure necessary to achieve these same goals, but at scale? So like, how can we take what BHC is doing and have that be relevant for the rest of the country? And so a lot of what they were talking about was this very same thing. Like, it's not so much that there isn't enough money, but there needs to be a reallocation of funding. And the second piece that they were really talking about is this new upcoming wave of public-private partnerships. So how can you leverage the basically the know-how and the ingenuity and innovation within technology that is in Silicon Valley and actually apply it to these huge, gnarly public sector problems? So if you guys haven't read that, I would recommend it. It's also a good way of seeing how does technology play into this. So yes, sort of getting into this from your perspective, like what role do you think that Silicon Valley technologists, data scientists can do to actually address this issue and actually help scale your work?
Well, I think that the wonderful thing about what we're discovering in looking at population health and the things that improve the health of whole communities is that it's really not rocket science. It's the kind of stuff that your grandmother taught you. And so the challenge, I think, is taking sort of technocracy and applying it to democracy. We want to essentially optimize democracy in our communities because ultimately that has the effect of giving people agency, some control, and a sense of that they have some sort of way of shaping their own destiny. And when you see communities that are suffering from poor health, typically they feel like they have very little control. So how can technology help optimize democracy? I think that those are the big challenges for us. We've seen clearly, and I don't want to get political, but we've seen clearly that our democracy is kind of broken. And the challenge with that is that it's not just bad in terms of people wanting to manifest their particular policies and express their ideas. That's a problem. But it has health implications. It has pretty profound health implications. So if we care about optimizing the health status of our communities, we have to optimize how our democracy works. And to the extent that technology can help, and I'm not a Silicon Valley, technologist like you and your friends, but something like voting. Mm-hmm. The last set of elections, we had something like 28% of the registered people voting. Mm-hmm. How can technology help that? How can we get more people to vote? How can we make voting easier so people can participate more easily in, not just in national elections, but in local elections and local conversations about how to use resources? All of these things are very technologically possible. I mean, can you vote from your smartphone? Can you create technology that allows people to essentially express their opinions and views much more easily so we get a much broader range of participation in decision making? That will have profound health impacts at the population level.
Great. And a lot of what we see from startups are really, they're trying to address those things you talked about. So how can you connect people to non-clinical resources, so getting outside the doctor's office? But then some of them are really trying to, address these health issues as sort of unmentionables. Like, how can we use technology to address addiction? How can we use technology to address mental illness or even loneliness? Like, I know that that's a social problem that has profound health impact on not just the elderly, but on just even a lot of people living in both rural and in urban areas. And so I think, a lot of what my co-founder and I talk about when we talk about the intersection of public health and tech is that yes, public health is very underfunded, and technology really hasn't really paid attention to some of these problems, but that represents an opportunity to solve new problems and to solve very important problems. So for those of you in the room that are looking for startup ideas and are curious about it, I would definitely encourage you to definitely take a look at Dr. Iton's work, but also just look at PubMed. Like, there's a lot of just research that gets published about in-person interventions that are very highly effective that could be delivered via technology that address many of these same problems with these populations, like low income, like homeless, like, kind of populations. And so a lot of what we see too when we connect with different universities is that they say, we've done this research, like we've proven this thing, and then it got published in a journal, but we don't act in the commercial space. We don't know what to do to actually, get this out of the ivory tower and have this show up in real life. So to the extent that all of us can kind of start looking outside of our doors, both technologists in the Valley, academics, yourself in the community, and really coming together, I think that that's going to represent a great opportunity to move things forward. And so that said, like, what do you think is one thing that the audience can do today to support your work and support the work of making communities more equitable?
Yeah. So, hi. So let me explain our work a little bit, and then in the questions and answers, if you want more specifics, I can go into more specifics. But so my job is a very strange job. I was hired, under the following conditions. My boss, who's a pediatrician, said, "Hey, Tony, I like the work you're doing in Alameda County, and we have this plan. We have $1 billion, and our goal is to improve the health status of Californians in a measurable way over a decade. And I'd like you to come in and design how we do that." And just before I said yes, he said, "There's one caveat, and that is you cannot spend a nickel on health care. So you have to do this entirely through the so-called social determinants of health. Find a way to measurably improve the health status of Californians over a 10-year period of time with $1 billion, focusing on 14 low-income communities around the state, with no money being spent on healthcare." And I said, "I'll take it." And the reason that was really exciting for me is because over the years of having practiced medicine and then working in health policy, I realized this notion that fundamentally what's really detracting from people's health across the board, across race, across class, across geography, is this sense of feeling connected, this sense of feeling that they belonged in a society where people work together, that they were working on something that was bigger than just their own self-interest. And bringing people together to work together on issues that are challenging not just individuals, but a whole community, not only is that good for creating policy, but it also improves the individual's health. The people who are working on that work feel better. So you get sort of a double bang for your buck. Now, the question was, what can this audience do to help advance that? Well, first of all, you are amongst the people that we at the California Endowment perceive as where our obligation is to help improve the health status of everybody in California. And part of the way we do that is we think that it's critical to rebuild California's social compact. And when I say social compact, I'm talking about that bundle of policies and strategies that essentially are investments in the well-being of the entire population across the age spectrum, across the race spectrum, across the geographical spectrum. Things like universal health care. Things like subsidized post-secondary education. Things like paid sick leave, paid vacations for people who are employed. Investments in public art and community facilities. Those are health protective investments. And the challenge is that most of us see health as health care. And our argument is that health care is necessary, but it's not sufficient. It's woefully insufficient to actually improve the health of populations. So the role of larger communities in improving health is essentially rebuilding our social compact in California. And that starts locally. That starts with local schools. That starts with parks. That starts with transportation systems. That starts with infrastructure, water in some of our communities. So we want to change the narrative about what health is in California. We think that that's already happening. And we can only do that when folks like you are engaged in this conversation to essentially change how we think about health and move it away just from health care and individual behaviors.
Thank you. And just to add a statistic to this for you guys, so they've shown through research that you invest $10 per person per year, or about $2.9 million, in community-based interventions that yields net savings of about $16 billion. So this definitely is a case of investing in this social compact pays, not just, of course, in outcomes, but also in terms of dollars as well. And so just as I think that we're getting close to questions now, so just to close this out, what's one tweetable call to action that you want to share with our live streamers and as social media as well?
Good God.
It helps.
Well, my fallback tweet is always, when it comes to your health, your zip code matters more than your genetic code. That should not be the case. Help us change that. So that's the tweet.
Sure, we got it.
This work is basically about decoupling that unholy pairing of zip code and health status. The reason that those things march together is because we have allowed it. We have created policies, or in many cases, we have ignored the need for policy in the face of abject need that has created conditions for people that are essentially stress incubators. We have stress incubators all throughout the United States that we've created, where people are essentially struggling to find the resources that we all know that people need to be healthy. It's not a mystery anymore. The interesting thing is that you take some of the most prestigious health institutions across the country, Johns Hopkins, Cleveland Clinic, and you look at where they're located, and you see that the communities in which they're located are the most unhealthy communities in the United States. We have to understand why that is. We can't turn a blind eye to that. Healthcare is important, but it's woefully insufficient to actually address the fundamental health status of Americans.
Definitely, and we are seeing that all the time, and they're starting to whisper and say, we realize that we're not actually doing enough in terms of whether it's addressing the needs of their immediate community or just looking at more broadly actually serving their mandate in terms of serving patients and consumers and communities. So for us, it's really looking at, the key to saving lives and money just requires looking upstream. Like, how do you leverage technology to address the social determinants of health and invest in technologies that actually ensure that everyone has a fair shot at living an entire lifetime?
I should say, this is not tweetable, but I should say that many of you have heard about this phenomenon of white working class mortality in the United States. It's sometimes referred to as the opiate epidemic, sometimes referred to as deaths of despair. And it's primarily it's a dramatic epidemiological phenomenon. We've seen probably about 500,000 excess deaths in the United States in white rural Americans, which is about the same number of deaths as the entire US HIV/AIDS epidemic. And this is over the past 20 years. And it's being driven primarily by three things: drug overdose, suicide, and alcohol-related morbidity and mortality. So self-inflicted injuries is driving one of the largest epidemics we have seen in modern public health in North America. I put it to you that what is driving that epidemic is exactly the same thing as is driving the epidemic of premature death in all those maps that I showed you in places like East Palo Alto and East Oakland and East Baltimore. It's fundamentally people losing hope and losing a sense of control over the things that are impacting their lives. And that is being driven by the lack of a social compact, a lack of solidarity across this country, which has led to the absence of universal policies. That's why we don't have universal health care, because we see people as my tribe needs to benefit, and we can only benefit if that tribe loses. And that is a an American phenomenon that is literally killing us. In California, we have the ability and we have a narrative in this state to actually approach this issue collectively, to recognize that we all do better when everybody does better. And we're moving that narrative to create policies that is rebuilding our social compact, which will ultimately take the burden off the healthcare system and improve the health of all Californians. That's our charge, and it's no small charge. And the gentleman in the White House is not helping us in that regard. So we're going to do something different here in California, and we're going to show the rest of the country how it gets done.
All right, well, we have a huge stack of questions here, so I'm going to try to get through as many as possible. This one actually has two. So can you share good examples of municipalities or regions that have changed policies and achieved these better healthcare outcomes? And then another one is, do health insurance companies understand, and what are they doing about it?
Yeah, great questions. Yes, there are some great examples. Richmond, California is one of them. Richmond is well, you probably know enough about Richmond, but it's got Chevron in it. It was a shipbuilding community for many years, and then it experienced enormous white flight and capital flight and disinvestment, and it's now rebuilding itself sort of in a 21st century model. And one of the things that Richmond has done that the rest of the state has since followed is Richmond looked at its general plan. The general plan is the Bible for how development happens in a community. And Richmond introduced the first health element in a general plan in California. And what that health element does is it requires all development to look at the health consequences of that development. It means that we know now that sprawl, for instance, creates obesity. Sprawl kills. There's a book called Sprawl Kills. Sprawl is essentially a design that basically makes it harder for people to walk or use bikes, and separating land uses by great distances, so people have to get in their cars to get to the grocery store or to the school or to wherever they need to go. We know that that kind of land use, which is the dominant pattern for modern California, has adverse health consequences. In Richmond, and now in some 40 or so other cities around the state, there are now health elements in the general plan which don't allow you to make those kinds of design decisions without understanding the health implications of those designs. So that's one example. There are multiple examples around the state of cities that are recognizing that health is an asset that they want to invest in. And they recognize that they can encourage people to come to their communities if they promote the health of their communities, both in design and just the general ethos of health in how they essentially manage their communities. What was the second part? The second question?
Just health insurance companies. What do they understand about this, and what are they doing about it?
I sit on a group called Moving Healthcare Upstream, which has a number of national health insurers on it. Health insurers get this. They totally get this. Their challenge is, and large healthcare institutions get this too. They realize that, the research that suggests that, what actually shapes population health says that healthcare is about 10% of what shapes health. So, somewhere between 70 and 90% of what shapes health has nothing to do with the doctor's office and pills. So health insurers realize this. They see this in their large population data sets, and they're trying to engage. Their challenge is that they're living in a reimbursement paradigm which has incentives to only look short term. And so if we want to change that, we have to create a new set of incentives for them, which requires policy change. They're not going to do it on their own. They're not stupid. They're motivated by their bottom line. Their bottom line right now incentivizes short-term decision-making, not longer-term thinking about making investments, primarily social services and social benefit investments in their populations to reduce the demand on the emergency room and the healthcare clinics.
And just so you guys know, you do see some health insurance companies being a little bit more progressive on this front. I know Kaiser Permanente.
Kaiser is a great example.
Yeah, Kaiser is a great example. They're an integrated, they both provide the healthcare and they insure you, so they tend to have a greater incentive because since it's an entire company, they're incentivized to save money on how much they spend on care. I know they just announced they reduced opioid prescriptions by 40%. There was another insurer today that I just saw that also, Intermountain Healthcare in Utah, which is a major health system out there that also in general is pretty progressive and innovative, has also made that same commitment even though they're not an insurer. So like to Dr. Iton's point, like these institutions get it, but one of the things that I brought up a little bit earlier before that maybe I should have clarified is that in terms of the ACA, a lot of people focus on the healthcare exchanges and insurance, but a lot of what people don't realize in terms of policy is that one of the biggest changes is helping to drive the shift to what is called value-based care. So right now, in terms of healthcare, people make money off of doing more, regardless of what happens to you as a patient or a consumer, in terms of if you get better, you get worse, or if you pass away. That doesn't matter. They get paid by performing things on you. What they're trying to do now with value-based care is really focused on, okay, we're actually going to pay you for performance. Like, does this person get better? Do they return to the hospital shortly thereafter after you discharge them, kind of signaling that you've done something wrong? And so in terms of really starting to align money with behavior, in terms of a behavioral economics perspective, that's what our healthcare system is trying to move toward. But now that we're in this transition period, we do have this issue of most stakeholders are still making their money in the old system, even while they're still trying to plan for the future. And so it's still a little bit gray and gnarly. And part of the same thing with the guy in the White House right now is that they seem to be taking steps to maybe roll back what was a very innovative step toward getting our healthcare system to where it needed to be. So it's still the kind of wait and see period. So next question. So in terms of your location-based analyses, have these been done in other countries, Canada, Japan?
Yeah,
France?
great question. The answer is yes. The much longer version of this slide set shows what we call a social gradient, which shows essentially how life expectancy decreases over geographic space. And the US has a relatively steep social gradient, meaning that as you move relatively short distances, your life expectancy gets shorter quick. Most countries have a social gradient. Canada has a social gradient. Most of Northern Europe has a social gradient. But it is much shallower than the United States. So there are consequences to living in a low-income community in other countries outside the United States, but those consequences are mitigated by a social compact, policies that essentially anticipate the needs of poor people and lower-income people and essentially create a basket of opportunities and benefits for them.
So this is related to how much does capitalism influence drive our poor healthcare outcomes and high healthcare expenditures?
I get this question a lot, and I try to remind people, I grew up in Canada. Canada is a capitalist country. Sweden is a capitalist country. Norway, Denmark, capitalist countries. France. The difference is that they have democracy that essentially is more important than their capitalism. So democracy checks their economic system. In this country, we seem to think, and interestingly, the word capitalism does not occur anywhere in the US Constitution. But we act as if it does, as if it is somehow this sort of holy notion that trumps democracy. And that's why we have corporations that are people and they can make unlimited campaign finance contributions. There's no other country in the world that has that sort of bizarre construction of capitalism. But we do, and it has profound health consequences. So the goal is essentially to enhance and optimize democracy to put checks on capitalism. But the countries that have some of the best health in the world are capitalistic countries.
And I would say even if you're looking at this purely from a market-based perspective, the fact that we are sicker as a population, especially particular parts of our populations, is bad for capitalism. If you are sick, it's hard for you to work. If you don't work, it's hard for you to consume things. And given that we are in a consumption-based economy, that would seem to undermine capitalism. So even if you're a strict economist kind of person, this is definitely something that you should want to support as well. So this question is about agencies. So this person asks, having more agency doesn't always lead to greater control. So how much benefit are you getting just from addressing agency alone versus looking at other factors or interventions?
Yeah, I'm not sure I understand the premise of that question, and I may challenge it a little bit, but I almost use agency and control synonymously, almost. Let me give a quick example. There may be some doctors in the room that probably understand this. When you're a physician, there's basically two types of patients. I mean, I'm oversimplifying, but there are like basically two types of patients. There's the patient who comes, that typically it's, the sort of stereotypical one is the VA patient. They come to see you and they're sort of slumped over in the chair, and they have diabetes, they have chronic obstructive pulmonary disease or emphysema, they have high blood pressure, they're on a whole list of medications, and they don't make eye contact with you, and you're talking to them, they say, yeah, doc, whatever you say, doc. And you're listening to that, and there's no way this person's going to follow any of the instructions that you're giving. And so you're trying to find a way in, a way to sort of like create for them a sense of control over what's happening, so they'll participate in this encounter as a partner. And on the other end of the spectrum is you have the patient who comes in with a stack of things they printed off the internet. And they're like, I read this, and I think I have this, tell me why I don't have this and why I don't need this drug. And you're kind of like, okay, well, can we focus on maybe 3 problems today, and then the other 27, subsequent. But those patients have agency. They are in a partnership with you. They're looking to you as a guide, not as sort of like somebody who's just going to disgorge information into their waiting beaks. They're going to critically and now analyze what it is that you're saying to them. And that partnership is so much better for health than a passive kind of partnership. And so agency is a sense that you have some sort of control over what's going to happen to you, and so you approach the world differently. And what we have found in our work is that we have communities that feel like that patient. Like they're like, whatever you say, doc, okay, whatever you say, mayor, whatever you say, board of supervisors. They're passive, they've given up, they've lost hope. And that is very bad for the health of that community. So the goal is essentially to build agency, the ability to participate. You start small wins. People can see themselves making change. You bring them together with similarly situated people, and then they can start to see that they have some control. And not only does that help change the policies, as I said earlier, it changes their physiology. It makes them more hopeful, and that hope ultimately is health. So I use agency. Now, if the questioner was asking about absolute control, none of us has absolute control, right? It's all relative. So we're talking about trying to build a relative sense of agency, so people have more control over what happens to them, not absolute control. And if I didn't get that question right, just ask me again afterwards. But I equate agency and a sense of control.
Great. So do you think that an integration of HHS and HUD could help better solve some of these issues at the federal level? It's very specific.
Oh, that's a great question. I love that question. And I will answer that question affirmatively. Yes, I think so. One of the most interesting meetings I ever attended was with the British Chancellor of the Exchequer, which is basically the Treasury Secretary in Britain. And they have kind of an accountability role in the British government, and they recognize that their public health system and their public education system were the same thing. And so they merged those two systems. And they said that if our public education system is not promoting public health, there's something very wrong. If our public health system is not promoting public education, there's something very wrong. So they tied the two systems together, gave them the same outcomes, and started to see improvements in health and improvements in education. And I think it's similar that when you siloize or fragment government and give them parallel goals, they tend not to work synergistically. And so trying to tie health and housing together, I think, is absolutely critical. And to the extent that it requires breaking down the silos and linking those two branches of government, I think that that potentially could have some benefit.
Great. So, person asks, you're going up against big medical institutions. Will they align with social spending? So I think really getting at that funding allocation question.
Yeah, so I give a talk at Johns Hopkins every year, Stanford, Harvard, about the same basic stuff, same basic data. And, people get it. There's no question that they get it. As I said earlier, they're being driven by a set of incentives. So to the extent that the questioner is asking, will they essentially ignore their primary incentives to essentially invest in the things that you're talking about? The answer is no. They will not, because they're rational. And they get rewarded for a different set of things than I'm encouraging them to pursue. So until they can start to see their incentives aligning with this work, nothing will change. You have very good leaders in many of these institutions that recognize that the future requires them to make these investments, so they're placing some bets now, but still the overall reimbursement structure is incentivizing them to do what Vanessa was describing, this short-term kind of, the more you procedurize somebody, the more you get reimbursed. The more you do, the more you get. So they are business people. They're trying to stay in business. They're trying to compete. So they're going to optimize their current reimbursement scheme as long as they can.
Exactly, and that's one of the reasons that we are excited that there are opportunities coming with the shift toward value-based care that creates opportunities for basically more businesses, because there are incentives there to meet these, well, they're not new needs, but they're new needs in the sense that there are now incentives to address these needs, to address the needs of low-income populations. And so, once again, like money drives everything. And so, I think with you, like one of the things that you can do if you're involved in California is really starting to better understand like how does healthcare get paid, and like starting to understand that, and seeing how that works, because it is very complicated. This is very complex. This person was asking, so where do we sign up to support your work by becoming a collaborative member of the movement, and will this help build single payer in California?
So I'm now speaking for myself as Tony Iton, not for the California Endowment. I'm a big supporter of single payer. I hate the term single payer, though. Call it Medicare for all, call it something for all. I grew up in Canada that have a single payer system there. It works beautifully. If you ask Canadians, there may be some in the room, what is the thing you love most about being Canadian? They'll talk about the Medicare system. And many countries around the world will say similar things. There is no American that will say it's the US healthcare system that they love most about being an American. Single payer makes sense, it's cost effective, it minimizes administrative costs, it minimizes marketing costs, and it delivers what we want, which is care. You can have a private system of care, private doctors, private hospitals. The insurance system in single payer is a public system. So it's not interested in competing, it's not marketing, it's not making profits, it's just administering care. The thing you want is care. And care, I personally think, is best delivered in a privatized system. I don't think that doctors that work for the government is a good configuration, because I think that the system needs to continue to be incentivized to innovate, and that happens better in a private kind of setting. But as far as insurance goes, there's literally no other country in the world that has decided that profit taking in health care delivery is the most important thing. We are very unique in that way. So single payer is a great system. I forget what the beginning of the question was.
Where do we sign up to support your work by becoming a collaborative member?
Yes, so go to our website at calendow.org, and there are multiple opportunities for people to sign up for various campaigns. We run a series of health campaigns across the state that include campaigns related to criminal justice and its health implications, to immigration, health implications, the mass incarceration system and trying to dismantle that, and its health implications, the school discipline system and its adverse health implications, particularly for boys and men of color, and our efforts to dismantle that. We're running campaigns statewide on these issues. You can participate in those campaigns. If you're social media savvy, you can click, support or whatever, and then you can move from there in terms of actually participating in rallies, writing letters, writing op-eds. There are a whole host of ways in which people can participate in this work.
Wonderful. So I think this might be for both of us. So how do you get businesses to invest in these communities to provide diverse, healthy food options and still profit?
Okay. So one of the things that we did, and this was for me, I'm a doctor, so I'm, we doctors, we know a little bit about, medicine. We know pretty much nothing about everything else. And when I came to work at the California Endowment, one of the things, and it was sort of a funny story, we were sort of sitting around eating lunch, and we were talking about all these food deserts across California. Food deserts are communities where there really isn't access to healthy food. You've got liquor stores, you've got tons of fast food, but you can't find a grocery store, you can't find a farmer's market, you can't find these kind of things. So we said, well, how do we get people to eat healthy if they can't find healthy food? What do we do about food deserts? And we're sitting around talking about this as a bunch of sort of public health wonks and doctors. And there were a group of investors that work for us. We're an endowment, so we have people that actually manage our $3.5 billion. And they're sitting here listening to us, and they're like, why don't you start a fund? And we're like, shut up, investors. You don't know anything about this. This is serious public health stuff. And they're like, no, seriously, start a fund. And so we started listening to them, and they were right. So we started the California Freshworks Fund, which is, our goal was to raise about $200 million to help build grocery stores in low-income food deserts. So we put $30 million into a fund, and we asked other people to match that, to participate in that, and by the end of 18 months, we had $300 million. And the California Freshworks Fund now builds full-service grocery stores in food deserts. We've built over 25 of them across the state. I did not know that you could do this. I mean, like I said, I'm a simple doctor, and I've learned a lesson in this, which is that money loves money. The second aspect that I've learned is that nobody wants to be the first one in. Everybody wants to be the second one in. So if you put your money out there at risk, which is what we do because we give away money, we put our money out there and we said, we'll take the first hit, if things go sideways on this. And next thing you know, we multiplied our money by tenfold. And so that fund exists today. It is building grocery stores across the state. It's something that can be done if there's a will and there's somebody who's willing to take that initial risk.
And I have to say, as an emerging fund manager myself, that this widespread misperception that people who are living in low-income communities don't buy things. We know that's ridiculous, both on its face and in terms of evidence. Like, obviously, people need to buy clothes, they need to buy food, they have to buy transportation, they're buying all sorts of technologies because they need them both for leisure and for work. And so in terms of this idea that providing healthy food options in what on its surface seems like not a good market doesn't make money, doesn't make any sense. It belies like real life. And we see that in other startups that have popped up. I think Propel just got funding from Andreessen Horowitz. Their app solely focuses on helping people who live on food stamps manage their food stamps. Does everything from manages how much money they still have left in their accounts. It helps them connect them to discounts to other grocery stores so that grocery stores who are participating and supporting this can actually see where their consumer buying, what their buying patterns are so they can understand how to better serve consumers and also make more money from this. Obviously, it's helping folks be able to budget food better and also have greater access to healthy food. It's definitely one of those everybody wins kind of situations, and I think it's a $70 million market or something like that, if I believe I'm remembering correctly. And that's just one example. There's other food-related startups. I think Thrive Market is a Series B, maybe C funded company that also, they're an online grocery store that kind of is like Trader Joe's in that they have a lot of kind of specialty products and a lot of organic products at decent prices, but they take folks who are on the food stamp program, they take that as payment now. So people who are living on food stamps can actually buy products online that are healthy if they are living in a food desert and still either want or need particular products if they have health needs that require these kinds of foods. So I would say, there definitely are opportunities out there if you are actually willing and ready to take them on hand and actually both make money and address some of these really huge issues, whether it's food insecurity or others. Let's see what else we got. Oh, that's in cursive, and I can't read that right now. So do you support SB 569, healthcare for all? I'm guessing that's the universal healthcare bill. I'm not very good at knowing.
Yes.
And then how do you use how do you use nurse practitioners in the community, parish, health nurses, and church communities?
Oh, so the question is about allied health professionals, ancillary health professionals, and other forms of practitioners. I'm actually married to a nurse practitioner. I actually would trust her much more with my care than I would trust me. She works at San Francisco and Southeast Health Center, which is in the Bayview Hunters Point. She deals with very complex patients. We have just closed up an initiative in California. It was a $90 million initiative on health workforce, where we made investments almost exclusively in nurse practitioners and physician assistants and other primary care providers to help build out California's health workforce. I went to medical school and graduated in 1989 at the time, and I went into a primary care internal medicine residency, which one of the first in the country. At the time, there was talk that, at some point, 70% of people leaving healthcare medical schools would go into primary care. I went to a school that actively discouraged primary care. And so it was a struggle to even, find a residency that my dean would write me a letter to support. That was 1989. As of last year, some less than 12% of medical school graduates in California chose a primary care career. Again, the incentive structure does not incentivize primary care. So we're not going to be able to build a healthcare workforce just with doctors. We're going to have to use other forms of healthcare delivery in order to essentially meet the demand, particularly for an aging population in California and across the country. And quite frankly, I think the quality of nurse practitioners, physician assistants in primary care is very good. They're very well trained, they have a lot of practice-based experience, and in some ways they provide better care because their training is much more focused on kind of holistic approaches to healthcare.
And as the daughter of a nursing professor, I would have to completely agree with that. For those of you who don't know, the physician shortage is and will continue to be a problem, but another one that doesn't get as much media attention, I think, is the nursing shortage. We don't have enough nurses. We're all really, really worse off. So once again, a role for technology, not necessarily to replace those people, but really to be able to extend the nurses and doctors that we do have in the workforce and allow them to operate at the top of their licensure and have basically to shift other tasks to other professionals even better. So now that I was able to read this is a multi-part question. So someone asked, you mentioned stress as a major factor about healthcare outcomes. So if you only have enough resources to address one component of stress, what level should you address that stress at? At the community level, at the state level, or at the federal level?
I'm not sure I entirely, unless you're talking about policy interventions.
I think it's a resource question. So if you're only you have limited resources to address the stress, like at what level should those resources be allocated?
Well, so, this is one of these Sophie's Choice kind of questions. So my approach in this work, I used to say, when I ran the Alameda County Public Health Department, I used to say that I had a budget of about $120 million, and we were part of an agency that was about $500 million. And I used to say that I would give half of my budget to anybody who could increase the graduation rate at Oakland Unified School System to 85%. And people would say, well, that's a very generous offer. Why would you do that? And I said, if there was an 85% graduation rate from Oakland Unified, I wouldn't need half my budget. So the point is that there are social determinants that are more important than other social determinants. Education is the most important modifiable social determinant of health, by far. If we could educate young people, get them through high school and to a post-secondary credential, give them a shot at a meaningful way to participate in the 21st century economy, our health would improve dramatically without doing anything with healthcare, without any new innovations in technology or pharmaceuticals. And we know this. This is not news. We know this. We just don't do it. So fundamentally, if I was going to invest at a sort of jurisdictional level, I would invest at the state level, because the state is constitutionally required to essentially ensure high-quality education for all of the residents of the state of California, and I would enforce that. I think that that's absolutely critical and would have profound health impact across the state.
All right. Well, those are all of our questions for this evening. I think we're wrapping up. Thank you guys for your listening, for your lovely questions, and we're here to answer them afterward as well.
Thank you.